Hello, and thank you for joining today's webinar titled Optimizing Telemetry Use, Current Opportunities and Future Perspectives, which will be presented by Dr. Kannan Mutharasan. My name is J.W. Beard. I'm the Chief Medical Officer of GE Healthcare Patient Care Solutions, and I'll be facilitating today's event. Cardiac telemetry monitoring is a valuable yet limited resource for hospitalized patients to detect and intervene on cardiac arrhythmias. It's been demonstrated as life-saving by providing alerts that enable responses to deterioration. It's also been associated with overuse, which can contribute to alarm burden for staff and potential risk for patients. In today's event, we'll be covering some topics on cardiac telemetry, including indications for use, evidence of overuse, strategies for optimization, and future opportunities in this field. Please note this webinar recording is exclusive property of GE Healthcare. No part of the following content may be copied or reproduced without prior written permission from GE Healthcare. A few items to orient on your screens today. There's a resources widget at the bottom of the page that you can use to bookmark this event for viewing at a future date. There's a Q&A widget where you're able to submit questions for Q&A at the end of our session today. There's a help widget that can be used to address any technical difficulties during this presentation. And finally, we do recommend closing other applications running in the background to optimize your viewing experience. This webinar will be posted on GE Healthcare's Clinical View website. This is a platform which is a free resource for medical professionals intended to provide educational materials and share best practices. Please browse the site and bookmark the page to view today's webinar at a later date and also look for past presentations along with upcoming future events. I'd now like to introduce today's speaker, Dr. Kannan Mutharasan. He is an associate professor of medicine and cardiology at Northwestern University's Feinberg School of Medicine and medical director for the South region of Northwestern Medicine's Bloom Cardiovascular Institute. Renowned for his expertise in telemetry and patient monitoring, Dr. Mutharasan has been passionate in advancing innovative approaches to optimize cardiac care. His leadership in implementing wireless and wearable continuous vital sign monitoring systems has addressed the challenges of telemetry overutilization, enhancing patient safety, and reducing alarm fatigue among healthcare providers. A passionate advocate for evidence-based practice, Dr. Mutharasan has contributed significantly to aligning clinical protocols at his institution with American Heart Association guidelines, ensuring efficient and effective patient care. As a thought leader in cardiology and health system innovation, Dr. Mutharasan continues to shape the future of patient monitoring through research, education, and clinical excellence. So Kannan, I hand it over to you. Thank you very much for your participation in today's event.
JW, thank you so much for that warm introduction, and welcome everyone. Good morning, good afternoon, good evening, wherever you are in the globe. I'm very happy to talk with you today about optimizing telemetry use, current opportunities and future perspectives. This really is a passion of ours, and I say ours, our whole clinical team has really been engaged in this in Northwestern Medicine. We're happy to share insights and learnings with you. So the learning objectives, the things that we're going to discuss today by the end of this webinar, and we're going to have a nice interactive discussion between JW and I after the formal presentation. One is to describe the appropriate indications for cardiac telemetry. Another is to analyze trends for telemetry overuse, understand opportunities for telemetry over optimization, and then preview some future opportunities for patient monitoring. So a lot of this really stems from the idea that cardiac telemetry is a wonderful tool to really help monitor patients and keep them safe. But there is this challenge that we encounter because telemetry overuse paradoxically will actually drive increased costs, provider burnout, and overuse that actually can impede clinical care. And we're going to dig into that, as well as strategies to actually help you at your institution to optimize utilization. So first, I'd start with a level setting set of slides, really an introduction to cardiac telemetry or continuous electrocardiographic monitoring. So what is it? It's a method of continuous remote monitoring of heart rhythm, heart rate, oxygen levels, and blood pressure. All of these can be integrated into a standard set of displays that help clinicians really take care of patients. The key aspect of this is it's real-time cardiac activity as well as vitals, as outlined above, that's sent to some type of monitoring station that's either central or unit-based. There has to be some mechanism to communicate back to the bedside, and the goal really is to detect arrhythmias and ischemic events to enable immediate intervention, to enable that ability for providers to really take care of a patient in a very rapid fashion. Now, I think one of the really important things to note is that telemetry is not just technology. It's really a communication system designed to create safety and drive action. So it's not just about the boxes, the wires, the leads, the infrastructure. It's about communication and conversation. And in medical school, we all learned about these standard control loops in physiology, and telemetry really walks through that. And I want to kind of share that framework with you. So any standard control loop really works on controlling some type of physiologic parameter. That data then goes back to a detector. There's communication to a coordinating center that does analysis on the data that's coming in. But then really importantly, you have to communicate that out to an effector or something that can do something about the parameter. And that requires action, clinical action. So when you think about a telemetry system, it's not just about the detector, which is where your mind immediately goes to. It's really about the patient being in the center, having that detection then displayed back through a communication system to a coordinating center, whether it's the nurse at the bedside or a remote telemetry technician that's monitoring multiple sets of patients. But then importantly, there has to be communication back to the people at the bedside who can actually take clinical action on the patient, checking on the patient, administering antiarrhythmic drugs, et cetera. So when we think about this entire control loop, there has been an evolution in telemetry in how it's implemented. So traditionally, it was always local or unit-based. And so that would look like monitoring that was happening directly on the ward of interest. And that communication would go directly to the nurse, or maybe it was even the bedside nurse monitoring the telemetry. That's fast and very simple, but it is very labor intensive because so many people have to be keeping eyes onto the telemetry monitor in order to make sure it's monitored at all times. We still see this in most intensive care units because of the need for such rapid intervention. The next evolution in our institution happened in the mid-2000s as central or hospital-based. So basically then in this scenario, there is a centralized room with multiple monitors and multiple monitoring techs. We're then monitoring that telemetry more centrally. That allows for more efficient staffing. But the downsides are you need a little bit more infrastructure, a room, more monitors, and a slight delay in communication between the telemetry tech and the bedside nurse. We find this now very commonly in many med-surg units. Increasingly, there's a movement in health systems to move to regional monitoring. So in other words, a centralized location within the city, if there are multiple hospitals in a city, allowing for even more efficient staffing and standardization, really helpful for rural hospital coverage where it may be hard to get staffing 24/7. Again, more cons in terms of communication lag, trust, and teamwork between people who may never see each other. So this is now deployed in multiple large health networks in North America, for example, Cleveland Clinic and HCA. And I think what is emerging and very exciting is cloud or AI enhanced telemetry, which really could be integrated multimodal smart systems that have predictive capabilities, support of human caregivers. Remember, standard telemetry monitoring has always relied on limits that are really just isolated in time, but this trend analysis really lends itself well to cloud or AI enhanced computing. Some of the cons are regulatory barriers, data security hurdles, and the expense of computing on such large sets of data. I think what we're seeing is emerging cloud or AI enhanced computing within some health networks. In North America, the FDA does pose real regulatory barriers to AI enhanced computing, but that is starting to come through and can be deployed at scale across health networks and institutions. Okay, so now that we all have a general sense of telemetry, I'd like to pivot then to telemetry indications and telemetry overuse. Who are the patients who need telemetry, and where are the patients that perhaps are getting telemetry but may not need it so much? So I think the single most comprehensive document around this is the American Heart Association 2017 guidelines update to practice standards for electrocardiographic monitoring in hospital settings. The European guidelines are more distributed across disease conditions, for example, ACS or bradycardia, tachycardia guidelines. The British Heart Rhythm Society has also published guidelines around this, but this is probably the single most comprehensive document that can be found internationally. And they divide this set of guidelines for who needs cardiac telemetry into three major categories: patients who need ST segment monitoring, patients who are at risk for developing ST elevation MI or ischemia, QT interval monitoring, typically looking for arrhythmia or patients who are getting loaded on certain types of drugs, and arrhythmia monitoring, bradycardia, tachycardia, ventricular tachycardia, et cetera. Now, one aspect of this guideline, it's very good at comprehensively addressing indications for telemetry, who needs telemetry, but the guidelines are relatively silent on addressing non-indications. In other words, explicitly stating who are the patients who do not need telemetry. And these are the patients of interest to us in terms of talking about telemetry waste, because these are the patients where if we can explicitly define, we can then articulate to our colleagues that these are patients who may not actually benefit from telemetry and may interfere with whole house comprehensive evaluation of patients who are at risk for arrhythmia. So this is taken from our institution. This was a team effort from multiple clinicians, nurses, administrators over years to really come up with a set of guidelines for who are the patients who need telemetry, but also just as importantly, and you see this in the bottom box, who are the patients where we really do not recommend telemetry because there is little added value in these patients. So these are listed out here: conditions like alcohol withdrawal, asthma or COPD exacerbation, gastrointestinal bleed, hypertensive urgency, fall without pre-syncope or syncope, pneumonia, post non-cardiac surgery, unless otherwise indicated because of arrhythmias that may have been detected otherwise, plain sinus tachycardia, or asymptomatic heart failure patients who are diuresing already have a defibrillator in place. So these are really important for us to be able to articulate to our clinicians that these aren't appropriate indications for telemetry. Can we think about using another strategy to make sure these patients are safe? I want to share this overview schematic when you're thinking about in your own institution how to reduce telemetry waste. There are really two major aspects to this. So one aspect is the new patient who comes in, whether a direct admission or through the emergency room via an ambulance or walk-in, who gets started on telemetry but didn't need telemetry from the get-go. These patients are depicted in the top red box. This we would consider waste. Patients who never had telemetry indicated. Then there's another cohort of patients where, while telemetry is indicated, it's not indicated for the entire hospital stay. And indeed, the patient may have been able to discontinue off telemetry 3 or 4 days into the hospitalization, but they remain on telemetry throughout the hospitalization. This is another cohort of waste. And really, this helps you graphically understand that the potential population of patients in whom telemetry is indicated compared to total telemetry bandwidth may actually be quite limited. So what do the data say? Well, the estimates vary very widely. The most of the data comes from North American institutions, and the estimates suggest, for example, at Ochsner Clinic in New Orleans, a tertiary care center, in 2018, up to 75% of telemetry days were inappropriate. When you pivot and look at, okay, the telemetry orders, who had inappropriate telemetry in the first place, the estimates range from 37 to 61% from University of Colorado to University of Chicago. And that 61% moved to 44% of inappropriate telemetry orders after a process improvement initiative took place. So I think the take home is there's significant room for improvement. There are many patients across our hospitals globally who are on cardiac telemetry where there is no indication for it. I think there are multiple drivers of telemetry overuse, and we can really empathize with many of them. So one is peer trends and customary practice in the community. If you're the one physician who isn't ordering telemetry on your patients where everyone else is, that may be a challenge. It may be hard to break out of what other people are doing, particularly with medical legal considerations. There can be a lack of awareness or understanding of clinical guidelines and the safety literature. There is this perception that telemetry facilitates earlier detection of decompensation, but the cardiac telemetry itself is not the only way that we can monitor patients for detection of decompensation, and we'll discuss that a little bit more too. And I think something that we can all really understand is this natural desire to make sure your patients are safe and have a way to keep an eye on a patient without having someone in the room. So these are all reasons, drivers where we see telemetry overuse. So I think this sets up a discussion, which I think we can dive into a little bit more in the Q&A as well, which is continuous vital signs monitoring for non-cardiac diagnoses really holds strong potential. Now, when you look at the literature outlining the predictive power of vital signs monitoring, not just continuous vital signs monitoring, but just simple routine vital signs monitoring that is intermittent for detection of decompensation, this method of clinical prediction is actually quite robust. There are many different scores, very simple scores that can often be hand calculated, like NEWS, MUSE, the CART score, that add up some of these clinical parameters and really give you a sense of who are the patients that are likely to decompensate over the next 24 hours. Respiratory rate, again, has been proven to be a very profound and rapid early method of detecting clinical decompensation. Respiratory rates above 22 are typically used as a cut point. Oxygen saturation is another signal. Heart rate, particularly heart rate trends, either bradycardia or tachycardia. Blood pressure monitoring, most often that mean arterial pressure. Temperature, and I would argue with the advent of AI and the ability to have cameras that are evaluating patients, level of consciousness will also come into this as a method of continuous vital signs monitoring. Now, much of the literature on continuous vital signs monitoring or vital signs for predictive analytics to understand decompensation is really focused on taking the patients who are not monitored and comparing those patients to the patients who are getting continuous vital signs monitoring. To my review, there is not yet any studies comparing the efficacy and safety of continuous vital signs monitoring as a substitute for telemetry monitoring, comparing these two strategies head to head to understand which is better at detecting decompensation. So I think these studies will come out as the literature, the technology continues to mature, but I think that's an important point to emphasize. Okay, so now that we've laid out a little bit about understanding that there is quite a burden of telemetry overuse, what are the consequences? Why does it matter that we're using this technology in patients who may not actually benefit from it? Yes, of course, we can all imagine that there's costs and there's infrastructure that's needed, but are there other downsides? So I think one important highlight that comes out from a very highly regarded institution, the ECRI, is in 2023 outlining the idea that telemetry overuse can lead to cognitive load and missed events. And it was actually highlighted as one of the top 10 health technology hazards for 2023. I think this is a very interesting document, worth a look. Health hazards like introducing air into rapid infusers or insecure cloud computer resources or disposables breaking or medication overrides. Out of all of the 10 top technology hazards in 2023 highlighted by ECRI, telemetry monitoring was the only one where we were providing a technology or something that was purported to give patients extra layer of safety, but yet paradoxically that overuse is actually considered to lead to missed clinical events and may actually harm patients. And the idea is that overuse of clinical cardiac telemetry can lead to clinician cognitive overload and missed critical events. And in their document, the ECRI states paradoxically increased use of cardiac telemetry monitoring for patients who do not require it can lead to patients overall being less effectively monitored. In other words, you start to develop a signal to noise problem. If you have telemetry on patients who don't need it, it can be harder and harder to detect that needle in the haystack, that one signal that you really need to be paying attention to as a clinical team and could harm another patient. So another aspect of this, but very related, is this idea that telemetry overuse increases alarm fatigue. It's a major source of alarm fatigue, and some units drives most alarms. Up to 72 to 99% of clinical alarms may be inaccurate depending on the unit and the alarm configuration. And the goal here is you want to have actionable alarms. You want to have alarms that the clinical team can respond to and do something about. You want to improve that signal to noise ratio and minimize the number of non-actionable alarms. This has been top of mind for many people who are very invested in patient safety. By the Joint Commission, one of the major safety organizations for patient care in the United States, telemetry overuse leading to alarm fatigue was issued as a central event alert in 2013. And the idea is this alarm fatigue leads to missed clinical events, clinical burnout, and more chaotic clinical environments. So telemetry overuse also increases costs. It's not hard to imagine this hardware, equipment, disposables all cost money. The estimates on cost really are very narrowly focused in the literature. They're focused on the direct costs, ranging about $30 to $50 a day in 2013 or 2018 US dollars. Certainly post-COVID, those numbers are much higher. Now, what costs are these when we're talking about $30 to $50 a day? It's really the direct cost, the cost of labor, the time it takes a nurse and the telemetry technician to tend to one patient monitor on telemetry for the day, plus the equipment disposables. In other words, the EKG leads, the paper that these telemetry strips may be printed on. These costs do not include the amortized value of the CapEx. And this compares to an average med-surg bed cost in the United States of about $3,000 a day. Now, this might seem like a small number compared to $3,000 a day, but when you consider that most hospitals in the United States, at least, are operating on a 1% to 2% margin, these costs become very real. It's very difficult to account for the indirect costs that also attend inappropriate use of telemetry. Certainly contributes to provider burnout. It leads to staffing problems in consequence, and then the retraining needs if providers burn out. Importantly, if telemetry is ordered, but there's no telemetry available for a patient, this can lead to holding patients in the emergency room, which we all know will lead to worse clinical outcomes, will make it more inefficient for the hospital to move patients through. And I think there's a very real opportunity cost of the care team not spending quite as much time at the bedside, counseling, teaching, and listening to patients. That human-centered part of care, which is really the joy of medicine, that gets detracted from when you have to attend to a monitor that is misbehaving. And certainly those capital investments are not captured in these costs. So what are the benefits then of reducing telemetry waste? Well, we've highlighted them now. Cost savings, better emergency department throughput, less alarm fatigue, less provider burnout, and I would say safer overall care for the patients in general in the house if we're able to eliminate some of the noise and be able to focus more on the signal for the patients who really need telemetry and alarm monitoring. Okay, so now that we've outlined the case for telemetry overuse leading to real costs, what interventions are effective for reducing telemetry overuse? And here captured is a list of interventions that our institution has undertaken over the last 6 to 8 years in really trying to reduce telemetry overuse. And I'm going to go through a couple of the types of interventions that have been used in and are found in the literature. So one is electronic medical records alerts and guidance provided by them. So this is a study from New York University, Quaternary Care Center in New York City, using the American Heart Association 2017 guidelines to help guide clinicians for various conditions, how long should telemetry monitoring be used? And you can see here things like high-risk chest pain, rule out myocardial infarction, rule out stroke. A new pacemaker telemetry, for example, right from the guidelines is recommended for approximately 24 hours, and so on. For example, AFib, 48 hours, and confirmed stroke until discontinued. And so when you look then in this study, how did providers respond to having this menu of options for deciding the length of telemetry monitoring? And you look on the right, you see that confirmed stroke was picked 22% of the time. It's not that in New York City, there is this amazing rash or epidemic of confirmed stroke. I think the authors wonder, and I wonder as well, well, if you have a way to get that electronic medical record alert to go away and not be bothered in 24 or 48 hours about whether or not that patient needs telemetry still, you might pick that. And so what they found was that there was actually low concordance between the selected indication for the telemetry monitor and the actual medical diagnosis of the patient for that hospital stay. And this is at a very highly respected cardiac center, NYU. So it does really bring up this question, do EMR pop-ups really work or do clinicians circumvent? And I would argue that this human-centered design is really important. So here's another study from Massachusetts General Hospital really looking at changing the defaults. So it's changing the framing of the choice, changing that choice architecture from what you see in the upper left, having EKG monitoring checked off by default for every patient coming into the house, to simply changing the EMR to not have that checked off as a default and needing the clinician to actually opt in to EKG monitoring or telemetry for the patient. And on the bottom left of the panel, you see the red line, a significant drop in telemetry utilization for patients coming into the hospital before and after this simple EMR change was implemented. Shown on the right is a very similar study by Dressler et al. Showing that after a launch of a new telemetry order set, they were actually able to be successful in reducing the number of telemetry orders per week. So I think comparing this slide to the last slide, it really matters how the telemetry orders are framed in order to optimally motivate clinician behavior. Another intervention that's often been tried and has a lot of success is a nurse-driven checklist, really empowering the bedside nurse through interdisciplinary rounds on the wards every morning to help prompt or motivate change in the patient's telemetry status. So here is a study combining a nurse-driven checklist with electronic health record alerts and evaluating the percentage of patients deemed to be inappropriate for telemetry. So in the left panel, the control group, you can see 37% of patients were deemed to have inappropriate telemetry. Adding in that nurse-driven checklist dropped that number down to 26%, and adding again an EHR tool dropped that down to 17%. And similarly on the right panel, we can see the telemetry duration deemed inappropriate also dropped. So I think that conversation between the nurse and the physician is a really powerful tool to help motivate appropriateness of telemetry. And this study also evaluates now the reduction in total telemetry usage shown on the left panel after an intervention, a modest reduction in telemetry utilization. But then on the right panel, really translating into a big decrease in perception of alarm fatigue. So the red box really represents pre-intervention, the score of alarm fatigue for this set of clinicians dropping from 82 to 55%. So I think this nicely demonstrates the link between reducing the amount of telemetry, reducing the amount of alarm fatigue, and therefore reducing provider burnout. Now, I would say that I think the appropriate thing to do is to really have a multimodal approach to interventions to help reduce telemetry utilization. So this is a study from University of Chicago, which layered on didactic sessions, EMR flags, educational posters, a refresher for new hires, and paging reminders and feedback for inappropriate telemetry utilization. You can see with each successive intervention, you get a concomitant decrease in telemetry orders. So for my American colleagues, I would say that telemetry, care and feeding of telemetry and appropriate use, it's a game of base hits, not home runs. You got to do a little bit of each. And for my European colleagues, I would say that really the approach is kind of like the Dutch approach to football, total football. It needs many touches in order to score a goal. So I think when you think about in your institutions, how do we reduce telemetry utilization? It really is about using multiple interventions layered on top of each other in order to get this problem under a little bit of control. So how do we reduce telemetry overuse and optimize performance? I wanted to share a little bit of insights from the literature as well as our own institution. I think this is a very nice document, 2018 from JAMA Internal Medicine, entitled Eliminating Inappropriate Telemetry Monitoring, an Evidence-Based Implementation Guide. And this really rests on 4 pillars, and I think these are spot on. So formulating a quality improvement team and recruiting the relevant stakeholders. You have to have the right people in the room from administration, nursing leadership, and physician leadership to acknowledge that this is an issue that we want to tackle and really have the levers to change behavior. Consider incorporating indication-based ordering and leveraging the electronic health record, though I think design of the EHR intervention is very important and has to be done thoughtfully in order to motivate the correct behavior. Implement routine review of telemetry appropriateness and use. Make sure that there is some feedback on how patients are getting telemetry ordered and how appropriate that is. And implementing education and training on AHA practice standards and safety. I think there is a knowledge gap and a knowledge deficit that can be addressed with simple educational tools, referencing the AHA standards, saying these are the recommendations for who needs telemetry, and these are recommendations who do not. So what are some of the metrics that we're using and can be considered to get a handle on who needs telemetry? So these are metrics of appropriate telemetry utilization. We would look at adherence to EMR-based telemetry order sets. How often does that correspond to the discharge diagnosis? I think for us, an operational metric that's very important is the number of patients who are held in the emergency department. There's a clean bed, but there's no telemetry box to apply that patient to. That really gives us a direct indicator of operational performance. And this is a very important thing to feed back to our ER colleagues, because if they're ordering telemetry on patients who don't need it, and that patient is then holding in the ER, making their work environment more chaotic, that is a very direct link that a change in behavior can improve quality of life and quality of care. I think a very easy and simple metric is discontinuation rates of telemetry prior to discharge. There will be times when a patient has telemetry on the day of discharge and they leave the hospital. But if you think about it, why did they need telemetry that day of discharge and then all of a sudden can go out into the world and not have telemetry? So that's a very powerful metric and a simple metric to measure. Percent of patients discharged with an active telemetry order, similar concept. Daily census of telemetry monitored patients. I think this gives you a whole house view of resource intensity. And then various parameters of length of telemetry orders. I think it's important not just to look at the mean, but also the median and examine the histogram, because there can be a very long tail of patients who have telemetry but do not necessarily need it. I think some metrics of effective alarm management that are also very important to dig into are audits of alarm burden per unit. Alarms per monitored bed per day is a standard metric to examine. That actionable alarm rate, that is an important thing to look at. Sometimes might need a little bit of hand calculation or intervention, but just for a few days on a unit, you can get deep insights into how you might want to tailor things. Looking then at the corresponding metric of false alarm rate is really important. And total number of artifact alarms, I think that's a big one to focus on. Which alarms are coming directly from artifact? I call it telemetry hygiene. Are we applying the electrodes properly? Are the batteries being changed on the telemetry monitors? This is a very simple way to make sure that you're getting rid of a lot of these nuisance alarms. I think really important is careful calibration of limit alarms for various arrhythmias. Examine your own institution's trends, your ability to respond to arrhythmias, and set those Brady limits and TACI limits to where you think it's appropriate for a given unit. Looking at the response time to an alarm from the time the alarm alerts to when it's cleared. And of course, I think very important to also look at staff satisfaction and alarm fatigue burden. So now we're going to pivot a little bit before we open it up to the discussion and the Q&A. Future opportunities for patient monitoring. What does this look like in the future? We've been discussing a lot about telemetry, how to use telemetry appropriately, how to really scale back telemetry to those patients who need it. What does patient monitoring look like in the future? So currently, I would display this as the continuum of care strategies to protect patient safety. After all, telemetry is just one tool in our toolbox in order to make sure patients are getting safe and therefore effective care. I think the standard, of course, is rounding on the patients, seeing them periodically, as well as getting vital signs intermittently. Most units, it's once a shift or every 8 hours at minimum, often Q4 hours. That applies really to all patients, and it's among the least intensive, but often very effective ways of monitoring patients. These early warning scores that we discussed that can be often calculated by hand or increasingly with technology is another way of detecting who are the patients at risk for decompensation, and can we think of interventions to help ward off that decompensation. I think clinician triage to the right unit, whether a patient needs a general medical surgical bed, needs a dedicated cardiac telemetry bed, a step-down bed, or intensive care unit, is an important aspect of patient safety. Continuous cardiac monitoring or telemetry, as we've been discussing, and of course, the advent of rapid response teams able to rapidly respond to any clinical deterioration, to lend a hand to the nurses and physicians on a given floor as a patient is acutely decompensating. I would argue this is the current state of what this continuum of care strategies looks like. And as we evolve into future state, this continuum will be more integrated, more seamless, and more comprehensive. So I think this rounding strategy will continue. Of course, we're all going to always see our patients, but vital signs monitoring will have an increasing role and will increasingly turn into continuous vital signs monitoring as cost of technology comes down, our ability to compute becomes faster. This will be a way to protect all patients in a less intensive manner. I think important will be AI-enabled early warning trends and deterioration. We're already seeing this come into clinical practice. I think where we really will benefit is the ability to detect trends. Remember, if a physician or a nurse or a telemetry tech who's monitoring multiple patients at once may not be as rapid at picking up a trend of tachycardia that might signify a patient entering a GI bleed, or a trend of bradycardia in a patient who is experiencing a respiratory decompensation. But computers never have to sleep and are often able to pick up these trends more rapidly than humans can. I think augmented intelligence will also really help us with clinician triage in terms of picking up who are the patients who need to be applied to a certain unit. And all of this technology, where we're thinking about continuous vital signs monitoring, telemetry, I think that's going to be really deeply integrated with our rapid response teams that are then able to integrate multiple health inputs, not just vitals, but also laboratory signals to understand and respond to and preempt clinical deterioration. So thank you very much. That concludes kind of the formal presentation. I really appreciate everyone's attention, and I'm going to hand it to JW to help moderate the Q&A and help lead the discussion.
Cannon, great presentation. Thank you very much. I felt like you touched on all these really important topics that are associated with cardiac telemetry, including pointing out some important resources for those in the audience and who may watch later, who are looking for resources to support their improvement efforts in their own institution. You mentioned the AHA guidelines, which are the kind of most comprehensive global standard at this point. In the literature, there's a couple parts of the guidelines that remain less defined than others. So for example, there's category 1, 2, 2A, 2B, and 3 type indications for telemetry. And then there's some other elements that are associated with patient conditions that the AHA didn't specifically comment on. So as an anesthesiologist, I've been in a position multiple times in the room with the surgeon towards the end of the case, and the surgeon says, "Where do you think this patient ought to go?" And frail patient, receives lots of fluids, going to require opioids post-op. Those patients will occasionally get pushed into tele for those reasons. What's your approach to kind of managing those types of patients where the teams are concerned? There's not a clear AHA indication there. So what's your approach to coaching them or helping your colleagues utilize the tele service most effectively?
Yeah, it's a great question. And I think particularly for surgical patients, everyone's tied to the surgical outcome. Everyone's concerned in the postoperative period that the patient navigate through well, particularly in those first 24 hours. Our approach generally is to help coach and understand that these are patients who are still being monitored. We have in our institutions often hourly rounding. The patient is being looked after. The vital signs are there. There are teams available to look at the patient, and telemetry doesn't have to add that much to this. And I think this is where continuous vital signs monitoring can really act as a bridge, because if we have this and are able to deploy this, I think one of the reasons I'm really excited about it is because it's a lot more lightweight for the patient, right? There are not a lot of electrode stickers on the chest. It's often just on the hand or the finger. The patient doesn't feel as encumbered. And if we have this as a bridge, now we can turn on the power of being able to continuously monitor the respiratory rate and the blood pressure potentially, and certainly the heart rate and the oxygen saturation. And between respiratory rate, oxygen saturation, the heart rate, if there's a patient, God forbid, is experiencing a postoperative bleed, you're going to see that signal in the patient becoming tachycardic or the blood pressure dropping or the oxygen or the respiratory rate going up. So I think it's two pieces. One is the piece of what do we have in current state and reassuring that this is important and helpful for the patient, but also how do we as a field move to a future state where we are more comprehensively addressing these concerns?
Yeah, those are great points. Another part of the AHA standards has to do with this duration of monitoring. So first, you had mentioned, you listed several different indications, and there's different durations, 24, 48, maybe a 72 in there, and then there's also kind of indefinite until seen by neurology. Why are the standards written that way with a specific recommended duration rather than looking at a clinical endpoint? Because you also mentioned that some patients will go home, will be discharged directly from tele to home. So they've kind of not, an endpoint has not been defined in their care that has led to them having tele discontinued. So what's the role of that timing guidance and versus using clinical endpoints?
Yeah, and I think the timing guidance is sort of a center of gravity for what likely duration of telemetry is needed for that particular condition. So for example, 24 hours for a chest pain rule out, really what the patient needs, at least in our hands and experience, is the 2 negative troponins and maybe 6 hours of monitoring, and they can come off pretty readily, or maybe even after 2 troponins, which now with high sensitivity troponin can be done in as little as an hour. So that's one part. And then, for example, atrial fibrillation with rapid ventricular response, it might take about 48 hours for a clinician to get that heart rate under control. So it's a guidance of central tendency more than anything else.
Yep. And then another question about just who gets access to the telemetry service. So does any admitting physician at your institution have the ability to send a patient to telemetry if that's their clinical judgment? Or do you have specific requirements for someone who utilizes cardiac telemetry in terms of either training or education?
Yeah, great question. So for us at Northwestern, it's any physician with admitting privileges can order cardiac telemetry. In contrast to example, an ICU where it's often a closed unit where the ICU physician has to accept the patient. Yep. And that may vary across places.
In the chat here, there's a question that can kind of get us started talking about the clinician experience in caring for patients in telemetry. So you mentioned one of the important elements of telemetry overuse is alarm burden, alarm fatigue, and then how that eventually can lead to reduced recognition of true emergencies. The question here is, what's the feedback we get from clinicians to improve the tele experience?
Yes, so I think for clinicians, and this isn't something that we fully touched on, but I think this is a great entree into that. I think it's important to really think about the patient experience, the nurse experience, or rather the caregivers are on the floor for that 12-hour shift, and then the physician or provider experience, right? Those aren't necessarily circles that completely overlap. So for the physician or nurse practitioner that's looking at a patient, a lot of times the motivation is, I just want to make sure my patient is safe, and that's what's causing me to order the telemetry. So what are the benefits of not ordering quite as much telemetry? And I would say, well, one, there's fewer things to look through in the morning, right? You don't have to look through the alarms on these patients if you don't have telemetry ordered on the patient. Another is it's very unlikely then if you have the patient on telemetry and there's a small alarm or arrhythmia, you're going to get the page in the middle of the night that, hey doc, the patient had 3 beats of non-sustained ventricular tachycardia. So that's a win. And then I think another part of it is kind of building, right? I think a big piece of this is getting telemetry in the hands of physicians or tracings in the hands of clinicians who can act on them, right? So there's multiple companies now that are able to deploy that telemetry tracing to a phone or a workstation while you're at home. And I think that's another dimension to telemetry that's really important in terms of, a clinician win.
Yep. Another question that's come into the Q&A is suggestions for clinician buy-in. And I'm interpreting this as, how do we get clinicians to buy in to the actual indications for telemetry monitoring, and then those who are not meeting those indications, kind of entrusting them to other parts of the hospital?
Yeah, super fantastic question. And I think what we've learned in our journey, it really depends on the clinician constituency you're talking to. So the message is a little different for ER, surgical colleagues, and hospital medicine colleagues. So the emergency room, I think my number one message is, if you are over ordering telemetry, you're very likely contributing to the ER holds that are making your days and nights less optimal, right? And so, I'll just share a quick story. One of the stories that I shared with my ER colleagues was, I took a styrofoam glass of water and I said, this is our fixed telemetry capacity. And every time you order telemetry, you're pouring some water into the glass. And if you have telemetry ordered, but we don't have any more telemetry capacity, then the glass overflows. I literally let it overflow. So I think that's the message for the ER, is if you are judicious with telemetry ordering, you can help reduce ER holds. So that's one. So for hospital medicine, I think they are all very tuned in already, particularly in hospitals with hospitalists, into length of stay and hospital efficiency. That's part of their DNA. They just innately want to be doing an appropriate job of care and don't want patients lingering or getting inappropriate care, by and large, in hospital medicine. And there we found a big lever is really across our hospitals, we have multidisciplinary rounds or interdisciplinary rounds, usually 10 or 11 o'clock in the morning after the patients have finished rounding, the docs have finished rounding, quick touch point checklists, not just for telemetry, but things like, hey, did they get a daily standing weight for heart failure? And then this is where the nurse or the charge nurse can say, hey, doc, does the patient still need telemetry? So I think that has been a profound approach. The incentives are a little bit different, quite honestly, right? For private physicians who are in clinic and are rounding in the hospital back and forth. I think there it's really that relationship between the nurse and the clinician, that relationship of trust, and just prompting and say, hey, does this patient still need telemetry? I think people are pretty responsive to that. I think for our surgical colleagues, we just kind of touched on it, but I think that is an important area of potential telemetry overuse in the hospital, and the messaging has to be, we're still watching this patient very closely. The telemetry isn't adding quite as much.
Yeah, and your point earlier about the availability of continuous vital sign monitoring in other parts of the hospital, I think is an important one. Because I think I use the example of a frail patient coming from the operating room after receiving a lot of fluid. That patient, not necessarily at risk for arrhythmia, and having the benefit of continuous ECG monitoring, but really the goal in those cases, I think, is oftentimes just continuous vital signs, concern about intermittent measurements on the floor. Do you have experience in kind of evaluating staff readiness in the general floor areas, non-telemetry use? Any sense of that staff's preparedness for continuous vital sign monitoring in addition to intermittent checks, really with the goal of identifying deterioration earlier and preventing severe adverse events?
Yes, so we do have at Northwestern Memorial Hospital some continuous vital signs monitoring in effect. And I think that for staff, it takes a little bit of time to get used to, but then they generally really like it. I think anytime we deploy new technology onto a floor, a little bit of a learning curve there. What does this mean? How do I calibrate myself to this? But the feeling that, okay, we are monitoring this patient, it really resonates with staff. So I think there's been broad staff acceptance around that idea.
Yeah, and I think I'm optimistic that this is an opportunity for reducing harm. And there's going to be more and more investment in this space and randomized controlled trials and other sources of really solid evidence that will expand continuous monitoring in these other units that will help, I think, decompress telemetry and leave those spots open for those who truly need it. On your telemetry units and in terms of staffing, so you mentioned a couple different approaches. There's everything from an arrhythmia alarm being sent directly to a provider, to a unit that's on the station, to even on that particular nursing station on that unit, even to a site in some systems that would be off campus responsible for multiple facilities simultaneously. What's been the kind of you mentioned the stepwise progression of the services in Northwestern. How has the staff greeted the various parts of these different staffing models? Do they like the tech or the tele RN contacting them directly? Do these nurses who are bedside clinicians also work in the kind of the central monitoring area? And how has this contributed to the overall, I think, health of the workforce and effectiveness of the unit?
Yeah, perfect question. So for us, we generally have centralized telemetry on the med-surg wards. In other words, it's a centralized room where a telemetry tech is monitoring up to 48 tracings at a time, which is what the AHA guideline recommends as a maximum number of tracings. So whatever vendor it is, typically 16 waveforms on 3 monitors. And I think broadly there's good acceptance of this. Now there are trade-offs, right? So one is, and I've seen this evolution over the last 10 years at our institution. In an effort to reduce alarm fatigue, the audible alarms are typically turned off on the med-surg wards, right? And so what does that mean for patient safety? Well, certainly makes the environment quieter. Is the bedside nurse as well equipped as they were 10 or 15 years ago to interpret and act on alarms, or are they relying more on the telemetry techs? I think there is broadly a greater reliance on telemetry techs for that skilled interpretation. And I think that's something that is a trade-off. Now, the really important thing to make it all work, and this goes back to some of the first few slides about how telemetry is a communication system, is there has to be deep and innate trust between the telemetry tech and the nurse.
Yep.
Because the nurse, the last thing, if you're trying to pass meds on 5 patients at night, the last thing you want to hear is, there's a nuisance alarm on my telemetry patient. Are they going to trust that signal? And so we generally, they're separate cohorts. Some nurses who are on light duty because of a workplace injury will often function as a telemetry tech, but
Yep.
they are separate disciplines. But what we do have is them actually, in onboarding, actually cross-rotate. So we'll have the nurse shadow in the telemetry room, we'll have the telemetry tech shadow on the floors, so they understand what environment the other is working in.
Yeah, I think that's a hugely important element, is that the recognition of what all elements of the team are doing as part of their responsibility in caring for these patients. An awareness of being in that central monitoring unit, seeing the number of patients that these techs and tele RNs are managing, I think is very helpful for the bedside RNs. Before the next question, I just want you to know you got a shout out here about your global sports analogies. Good job pulling in both American baseball and some Dutch football. I want to talk a little bit about the patient experience. And I think this also ties to, if there's trust between the techs and the bedside clinicians, there's going to potentially be faster response time to some of these alarms that are coming through. So in the literature, there's different elements of patient experience in telemetry. It's everything from kind of feeling reassured with prompt response to an alarm to actually being concerned if something's been alarming for a while and no one's come. What's your perspective of the key elements of the patient experience and anything that you all have done to improve that?
So I think what you just touched on, which is patients do feel reassured by being watched in some way. That really is important. For me, when I have family members in the hospital, right, there is some reassurance that comes from, okay, they're being monitored, whether it's continuous vital signs monitoring or telemetry. That piece. The other piece is, it can, if the alarm hygiene isn't so great, right, it can be concerning that someone's coming in to check on things or adjust things. I have patients often say, everyone ran in the middle of the night and it really alarmed me. It scared me. I was feeling fine. I was fast asleep. So that touches on the fact that if we're going to have telemetry monitoring, have it on the appropriate patients and do a good job with the leads and the batteries for sure. I think another part of it also is, the telemetry packages have always been just a little bit bulky for patients, right? So kind of, is it hanging around your neck? Is it in the hospital gown pouch? I think that weight, it actually is something that patients don't love, and they are happy when it gets discontinued. So I think those would be the three key dimensions I'd highlight.
Yeah, and I think, with miniaturization of electronics, improved wireless communication, et cetera, I think we're going to see much more favorable form factors for what the patients are actually wearing. And these, the leads that are hanging down that may get snagged on the gown, these disconnections and things will hopefully be reduced significantly in the future, along with, improved battery life, things like that with some of these advances. We have a couple minutes here. I just want to talk a little bit about the future of telemetry. So we've touched a little bit on what the flow of a patient in a hospital could be. Maybe it's someone who comes in, is getting ruled out with chest pain, and then they're discharged from tele to a hospital unit, and then at some point they're going to go home. What's your perspective on kind of the flow of data acquisition that would maybe accompany that patient? If it went continuous tele to continuous monitoring on the floor, what are the opportunities to continuously monitor that person at home in some kind of less intensive manner?
Yeah, so this really highlights a trend that's emerging, which is this idea of hospital at home, where these patients can get potentially hospital level care, but don't need to be within the four walls of the hospital. And I think what we're going to continue to see is more of a seamless blend of many things, including the continuum you just described, but also the idea of what is a hospitalized patient. And to me, there is a certain level of acuity which will always belong inside a hospital. But increasingly, for example, patients who have heart failure, who are diuresing, we've started doing hospital at home at some of our sites for these patients. These are patients that traditionally, by standards, would need centralized telemetry. We don't have centralized telemetry at home because the response time would obviate its utility. But we do have intermittent vital signs monitoring, but wouldn't it be nice to have continuous monitoring? So I think what we're going to see is, especially as cost drops and the bulkiness improves, battery life improves, continuous monitoring for patients who are getting interventions or more intensive treatments will emerge as something that at some future state will emerge as a standard of care.
I agree with those assessments. Okay, this is going to be our last question. No webinar would be complete without a question about AI. So AI has demonstrated its ability to identify various, whether it be structural heart disease, risk for arrhythmia, et cetera, and 12-lead ECG, kind of the cart-based diagnostic ECG. What are the opportunities for AI and continuous ECG in the telemetry unit?
I think one is arrhythmia detection or trends. So just starting with heart rate itself, I think bradycardia, tachycardia trends are very powerful for detecting non-cardiac clinical decompensation. So I think being able to look into that will be very helpful. I think AI is able to derive enormous insights from things like how the QRS complex is configured to understanding whether a patient is at risk for certain arrhythmias. I think AI is going to have insights into things like PVC burden, predicting the propensity for ventricular tachycardia. I think these are things that the general gestalt for it may be much better. So in short, AI will be able to help us really predict decompensation and potentially head it off.
Yeah, I'm optimistic too. There's going to be signals that a machine learning algorithm may be able to find in a continuous waveform that are suggestive that there's an increasing probability of a certain type, more concerning, more dangerous arrhythmia. So I also hope that we get there in the near future. So we've come to the end of our time here, Ken, and I just want to thank you very much for sharing your expertise with us and your audience. And to our audience, thank you all very much for attending. I'd like to remind you that this webinar will be available on the GE Healthcare Clinical View website for viewing at a future date. And we appreciate your feedback on these events. So after this event, you will have an opportunity to complete a short survey. We'd appreciate it if you can take a few minutes to do that. And with this, Cannon, thank you again. And to our audience, thank you again. Our webinar is now concluded. Thanks.
Thank you.